Okay, this is Module 6, Pharmacotherapeutics for the Management of Pain Overview. This is PC 707, Advanced Pharmacology. This module reviews the pharmacokinetics and pharmacodynamics for those agents commonly used to manage pain and inflammatory conditions. Evidence-based practice, resources, and treatment principles used when prescribing analgesic and inflammatory agents are presented, including treatment of acute, chronic, neuropathic, colic, and procedural pain. This module is divided into 3 units. Unit A, opioid analgesics, B, non-opioid analgesics, C, headaches and fibromyalgia. So Module A, Introduction to Pain. Pain is the most widespread reported medical problem. This module will briefly review the etiology and types of pain and more extensively the pharmacologic management of pain. The APRN is faced with many challenges when it comes to treating pain. Understanding classifications of pain and pain assessment are key in developing an appropriate treatment plan. In Module 1, you are required to review your individual state regulations related to prescribing practices in your state. The regulations are subject to change, and it is your responsibility to stay up to date and in compliance. President Obama signed into law the Comprehensive Addiction and Recovery 2016. The new law expanded the authority of APRNs to treat opioid addictions with buprenorphine in office-based settings. There is a requirement to obtain a waiver to do so. If this is of interest to you, check out the Substance Abuse Mental Health Administration website for more information. In 2016, the General Assembly of Virginia, state law, passed laws that require the Board of Medicine to identify prescribers who should complete 2 hours of continuing education related to pain management. This was a new requirement in response to the ongoing opioid epidemic. Non-compliance could prevent an APRN from relicensing. It is absolutely essential that you understand and are compliant with your state and federal prescribing laws. For example, in Virginia, an APRN may prescribe Schedule 2 through 5 drugs, and prescriptive authority is granted from both the Board of Nursing and the Board of Medicine. The APRN must have a DEA number and a prescription monitoring registration and a collaborative practice agreement with a physician. In Arizona, an APRN prescribed Schedules 2 through 5 must have a DEA number and is overseen by the Board of Nursing. Go back now and review your own state prescribing requirements. What schedules can you prescribe? Any certain number of pills or time restrictions? That covers state requirements. Now you need to be sure you understand federal requirements. In order to prescribe scheduled drugs, you must have a DEA number. Go to the DEA website and review how to obtain your DEA number. The following information must be provided when prescribing a controlled substance: date of issue, patient's name and address, practitioner's name, address, and DEA registration number, drug name, drug strength, dosage form, quantity prescribed, directions for use, number of refills, if any, that are authorized, manual signature of prescriber. For example, you can have the clinic name and address, the practitioner name, and then the patient, John Doe, date of birth, and then the date that you're prescribing oxycodone, 5 milligrams, dispense 30, and write out 30. The SIG, 1 tablet Q, 4 to 6 hours, PM, PRN, back pain. Do not drive or use hazardous machinery until response is known. May cause drowsiness. Do not exceed 6 tablets per day. No refills. And then prescriber name, title, and DEA number on file in pharmacy. Review the classifications of controlled substances. Understand refill parameters for each schedule. Complete the upgraded self-review worksheet. Also review regulations of disposal of return of controlled substances to the pharmacy. Due to increasing opioid addiction issues, it is important to provide patient education on safe storage of prescriptions. Ensuring that children and adolescents do not have access to these medications is essential for the safety of the child. Disposing of unused prescriptions is an important step toward preventing accidental overdose and diversion. A friend of mine who works at a pharmacy discussed how the pharmacy double counts prescriptions to ensure that correct number of pills are dispensed. The pharmacy began to notice several older patients who complained that the pharmacy repeatedly shorted them. After review with the patients, it became evident that family members were diverting the pills. Patient education that includes proper disposal is an important step in curbing the epidemic. Many community sheriff's offices are participating with the DEA in Take Back Disposal Days. Check to see what is happening in your community. Opioid overdose is now the leading cause of injury death in the U.S. and an increasing public health issue. The news and social media often have photos of unfortunate overdose occurrences, often with small children in the area or left orphaned. Naloxone, a life-saving medication used in opioid overdose, has been used for years in medical settings. Due to increasing overdose deaths, there is a current push to make it easier for family and first responders to have easier access and delivery of naloxone. Recently, the FDA approved naloxone nasal spray. Be familiar with formulations and delivery. In order to treat pain effectively, one must assess pain accurately and then offer treatment that may include medication and additional interventions and therapies. Pain is often undertreated by healthcare professionals worry of liability issues or creating patient dependence and/or addiction. The WHO Pain Ladder organizes the appropriate steps to treat pain. Note that when opioids are needed, the smallest dose for the shortest amount of time is advised, in which case physical dependence from opioid use is extremely rare. At the same time, sometimes larger doses for longer periods of time are necessary. If and when physical dependence does occur, addiction and abuse are both still very uncommon. While the provider must always maintain a safe and discerning approach, opioids may be required to appropriately manage pain. When long-term treatment is needed, nurse practitioners often co-manage with the pain clinic in order to maximize patient care and safety. Different types of pain. There's nociceptive pain, such as arthropathies, ischemic disorders, myalgias, skin and mucosal ulcerations, superficial pain, such as burns, and visceral pain, such as appendicitis, pancreatitis, renal lithiasis, etc. Neuropathic pain, neuropathies, as in alcoholism and diabetes, cancer-related pain, regional pain syndromes, HIV, multiple sclerosis, phantom limb pain, post-herpetic neuralgia, trigeminal neuralgia, and post-CVA pain. Then there is mixed pain of mixed or undetermined etiology, such as chronic recurrent headaches and vasculitis. Classification of pain. There are multiple classifications of pain. For this course, we will define acute as sudden onset and of short duration, and chronic as lasting 3 to 6 months or longer. These are simplistic categorizations, as there are many variations within these categories. For those of you who have a unique interest in pain and pain management, we suggest that you go to the International Association for the Study of Pain. Pain is categorized into 4 different types based on timing, intensity, and duration. In 1986, the World Health Organization developed a pain relief ladder. Its original use was for the treatment of cancer pain, but was soon accepted as a framework for the treatment of acute and chronic pain. Over the years, the WHO Pain Ladder has undergone 2 revisions. Presented below are the first and third revision. The latest adaptation takes into consideration newer pain treatments and adjuncts. Be sure to note the stepwise treatment approach. I'll be right back. Remember these 5 points for pain management from the original WHO ladder. Number 1, give oral analgesics first. Number 2, give analgesics at regular intervals and adjust the dosage until the patient is comfortable. Number 3, prescribe analgesics according to pain intensity as evaluated by scale of intensity of pain. Dosing of pain medication should be adapted to the individual. The correct dose is one that will allow adequate pain relief. Number 5, provide a detailed written plan for the patient and family. A modified WHO pain ladder includes a 4th step of treatment of crises and chronic pain. Also included are new opioids such as tramadol, oxycodone, hydromorphone, and buprenorphine, along with the new methods of administration that were not available in 1986 in the original ladder. Methadone is found in step 3 and is very useful in the treatment of cancer pain, chronic non-cancer pain, and refractory neuropathic pain non-responsive to traditional treatment. Adjunctive meds suggested include steroids, anxiolytics, antidepressants, hypnotics, anticonvulsants such as gabapentin and pregabalin, and NMDA receptor antagonists for neuropathic pain. Cannabinoids can also be included in this group. Types of pain. Pain medications are in one of the following categories. Number 1, opioid. Some sources differentiate between opiates, which are derived from opium, and opioids, which are synthetic. For this course, these categories are combined. Also, the term narcotic is a nonspecific term, and opioid is our preferred term for the pharmacologic agents we will discuss and use. Number 2, there's non-opioid pain medications, and number 3, there's adjunctive ones. The mechanism of action of opioids is related to the binding of specific opioid receptors, primarily in the CNS, spinal cord, and gastrointestinal tract. There are 4 classes of receptors. Number 1, there's a mu receptor, which demonstrates the classic effects associated with opiates, such as analgesia, respiratory depression, and euphoria. Examples are morphine, Cadian, meperidine, which is Demerol, fentanyl, which is Sublimase, sufentanil, which is Sufenta, and hydromorphone, hydrochloride, which is Dilaudid. Number 2, there's kappa receptor stimulation, which provides analgesia, sedation, and examples of these are Nubain and Stadol. There's delta receptor stimulation, which causes dysphoria and hallucinations, and sigma receptor stimulation, which also causes dysphoria and hallucinations. The drugs that stimulate the mu receptor all stimulate the kappa receptor to some extent, which is why you see sedation with these medications. The drugs that act on the kappa receptor exclusively are the agonist-antagonists. These drugs act weakly on the mu receptor, but strongly at the kappa receptor. Therefore, the effect seen in analgesia with less respiratory depression than seen with the drugs listed above that bind preferentially to mu receptors. Examples are nalbuphine, such as Nubain, and butorphanol, such as Stadol. Little is known about the 2 last receptors that are delta and sigma. The types of opioid agonists, there are strong agonists, such as morphine, which is Cadian, hydromorphone, oxymorphone, heroin, meperidine, which is Demerol, methadone, which is Dolophine, fentanyl, which is Sublimase, and sufentanil, which is Sufenta. Then there's moderate agonists, such as codeine, which is Tylenol with codeine, propoxyphene, which is Darvon, oxycodone, and hydrocodone. There are mixed agonists, antagonists, such as butorphanol, which is Stadol, and nalbuphine, which is Nubain. And then there's antagonists, naloxone and Narcan. Pain management in children. Children commonly experience pain. Pain can result from injury, illness, and medical procedures. Care providers often underassess and undertreat pain in children. This may be related to fear of use of medication in children, inadequate knowledge in the care provider, children's inability to express pain, or the belief that infants do not have mature enough neurological systems to process pain. Pain increases anxiety in both the patient and the parents. Providers have an ethical responsibility to appropriately treat pediatric pain. In your required reading, you will find the assessment and management of acute pain in infants, children, and adolescents. Carefully read the article and focus on the key points in facilitating the comfort of pain management in children. Pain management in the elderly. Pain management in the adult over 65 presents several challenges. Physiological changes of aging and comorbid conditions can increase the pain threshold in older adults. Changes of aging often include chronic pain issues such as arthritis. Cognitive impairment and dementia can complicate effective communication and adequate assessment of pain. Pain assessment tools aid in assessment and treatment of the cognitively impaired adult. Examples of these tools can be found at the Alzheimer's Disease Association webpage. Many patients and providers inadequately treat pain and simply dismiss pain as a common part of aging. Comorbid conditions complicate treatment choices. For example, impaired renal or liver function could limit potential treatment choices. For this reason, you will need to understand drug clearance and precautions for selected drugs. Drug-to-drug interactions must also be considered when the patient is on multiple medications for existing conditions. For example, a history of GI bleed or MI excludes the use of NSAIDs. Pain management and pregnancy. Most of the literature on opioid use during pregnancy covers methadone for addiction and opioid use for analgesia in labor. However, acute and chronic pain are common issues that present a pharmacologic challenge during pregnancy. Non-pharmacologic treatments and alternative treatments are consistently first line, but the clinician must be familiar with the risks and benefits of all options. Other than acetaminophen, few non-opioid analgesics are considered safe for use during pregnancy. Therefore, the clinician must provide extensive teaching, include the patient in decision-making, document extensively, and refer to a pain clinic or specialist as needed. Due to their lipophilic nature, all opioids readily enter the fetal placental unit. Adverse effects of opioids include miscarriage, fetal growth restriction, preeclampsia, premature rupture of the membranes, preterm delivery, and stillbirth. Chronic opioid therapy, COT, should be avoided during pregnancy. If opioid use is necessary, a woman should use the lowest effective dose for the briefest amount of time possible. Opioid addiction during pregnancy. Historically, methadone has been the mainstay treatment for women with opioid addiction during pregnancy. However, recently, buprenorphine has become more popular due to its accessibility and association with better neonatal outcomes. In March 2016, the FDA alerted providers of the increased risk of serotonin syndrome associated with methadone, further supporting the trend towards buprenorphine as the preferred option. Please refer to M9 course readings for further information on this topic. Pain management and breastfeeding. Newborns exposed to opioids during pregnancy and labor may need resuscitative assistance and may have problems with adaptation during the newborn transition period. Adverse effects include neonatal respiratory depression, decreased alertness, and compromised sucking reflex. Chronic opioid exposure may cause neonatal withdrawal symptoms, including difficulty with temperature regulation, feeding, hydration, seizures, and sudden infant death syndrome. Opioids used to treat postpartum pain are usually given in small doses and for brief periods of time with few side effects. However, there are significant exceptions. Recall the Women's Health case in Module 1, the postpartum mother who was an extensive metabolizer of codeine and the newborn death that ensued. While the accident with codeine represents a rare phenomenon, hydrocodone may be a safer alternative, such as Vicodin, Vicoprofen, Narco, Lorcet, Lortab, as it does not increase in strength when metabolized. No matter the opioid, all newborns must be monitored for changes in feeding or sleeping patterns, level of alertness, or any significant changes in behavior. Finally, opioid use during pregnancy, labor, or postpartum may predispose those newborns to long-term sequelae such as self-destructive behavior, suicide, and amphetamine or opioid addiction. Conclusive, but the potential for sequelae deserves serious consideration. Risk-benefit counseling is crucial for opioid use in pregnancy and lactation, as well as collaboration and referral to appropriate resources and a multidisciplinary approach. Drug-seeking behavior. A more unpleasant aspect of primary care is dealing with drug-seeking behavior. Many nurses have experienced discomfort in dealing with the issue for many reasons, including personal baggage, past experiences, moral judgment, anger over manipulation and coercion, and fear of losing our licenses. We need to start with an understanding that every patient is entitled to a thorough evaluation at every visit. This includes a history, physical exam, and tests as indicated. Even people with addiction issues or mental health issues can have illness or exacerbation of issues. You would not want to be responsible for missing a medical issue. That said, you do not have to prescribe the prescription that the patient desires. Be willing to address the issue head-on in an honest way. There are tools at your disposal. Be familiar with your state's prescription monitoring programs. Now is a good time to look up the name and process for each state. We also have pain management clinics. Be aware that patients in pain management will have contracts that state if they get controlled substances from any other provider, they are discharged from care. Be careful not to write prescriptions without consulting with the pain management clinic for those patients. Protecting yourself. It's holiday break. You have big plans with your family. Your favorite sister, husband, cousin, or self just pulled a back muscle. The pain is unbearable. No one wants to go to the ER. Could you just write a prescription for pain medication and maybe a muscle relaxant? No, not even once. While your family or friends may have very compelling arguments as to why this is a one-time only right thing to do, it simply is not. Every person, including yourself, is entitled to and deserves quality care. A complete evaluation and medical record need to be generated. Anything otherwise really is poor care and risky. In many states, it is illegal. Medical associations and some state boards consider it unethical, and you may suffer serious repercussions. Some states forbid prescribers from writing for controlled drugs for themselves or close family members. The safest approach is to say no from the onset. It is your license at stake. I know it is hard. I just tell the person that their health is so important that I insist on equality, evaluation, and care, and that I am unwilling to risk my license. Patient education. Be sure to teach your patients about combination products and or adding additional pain relievers. Watch for total daily intake of acetaminophen and NSAIDs. Remember to assess for alcohol intake and discuss the use of alcohol with opiates and the increased risk of respiratory depression. Discuss that it is illegal to share these drugs. Sharing opiates with opiate-naive individuals could be fatal. Remember, some of the opiates are not for opiate-naive patients, and your patient dose may have been titrated up over time. This means if they share the same dose they are on with their opiate-naive twin, it could result in overdose. Teach your patient about the signs and symptoms of overdose and that additional non-opiate meds can increase risk of overdose. Benzodiazepines, CYP3A4 inhibitors, and even alcohol. Remember to teach about dosing schedule and about expected onset of action. If your patient takes their medication and expects relief sooner than possible, they may think they need to take more. Educate about when to take any action, and peak effects are key to patients setting realistic expectations. Be sure to caution about sedation effects and work and driving. Educate your patient about child safety and storage. Also, educate your patients about safe storage. There are many tools available to help you with patient education. See the FDA's Safe Use of Patient Education material. Unit B, non-opioid analgesics and muscle relaxants. The art of pain medicine. The cardinal signs of inflammation, redness, swelling, heat, and pain have been identified as a syndrome since the beginning of recorded medical history. Non-opioid analgesics include number 1, non-steroidal anti-inflammatory drugs, NSAIDs and aspirin, and number 2, acetaminophen, which is Tylenol. These drugs all have antipyretic properties as well as analgesic properties. The non-steroidal anti-inflammatory drugs, which are NSAIDs, the mechanism of action. NSAIDs inhibit prostaglandin formation. Prostaglandins sensitize pain receptors to bradykinin and other biochemical mediators, causing vasodilation and increased vascular permeability. The result of their effects is inflammatory exudate and the 4 classic signs of inflammation: pain, heat, swelling, and redness. By blocking the production of prostaglandins, NSAIDs have the AAA effect. They are analgesic, antipyretic, and anti-inflammatory in action. However, prostaglandins also have protective functions, which is why blocking their action causes the many adverse effects seen with the use of NSAIDs. These include GI effects, because prostaglandins protect gastric mucosa by increasing mucosal production and inhibiting gastric acid production. One can see why NSAIDs are commonly associated with gastrointestinal upset. In fact, GI bleeding secondary to NSAID use is responsible for 100,000 hospitalizations annually. This is a significant adverse effect. Renal effects. Some prostaglandins ensure renal blood flow via vasodilation actions. This is why clients with impaired renal function should not use NSAIDs. Blood effects. Aspirin irreversibly blocks the production of the prostaglandin thromboxane in platelets. Because thromboxane supports platelet aggregation, and because platelets cannot remanufacture this prostaglandin once it's countered, this effect lasts for the duration of the platelet's life. Cardiovascular risk usually increases with higher doses, longer duration, and with NSAIDs that are more COX-2 selective. The highest risk is with diclofenac and celecoxib, followed by meloxicam, etodolac, with naproxen being the lowest cardiovascular risk. GI risk increases with higher doses and longer-acting products. Piroxicam and ketorolac have the highest GI risk, while ibuprofen and celecoxib have the lowest GI risk. Use an NSAID plus a PPI for those with moderate GI risk due to 1 or 2 risk factors. Number 1, if they're over 65 years of age. Number 2, if they're on daily aspirin therapy. Number 3, if they have had a previous uncomplicated ulcer. Or number 4, are on high-dose NSAIDs. What are NSAIDs? Aspirin, ASA/salicylates. Aspirin, Bayer aspirin is the prototypic NSAID but has distinct properties that make it somewhat unique. It is used as the drug of choice for several conditions: protection against clotting disorders, as a secondary preventive measure, as an antipyretic for effective relief of mild to moderate pain, and as an anti-inflammatory for rheumatoid arthritis, tendinitis, and bursitis, just to name a few. Aspirin has an irreversible effect on platelet aggregating properties and therefore increases the risk for bleeding for the life of the platelets it contacts. Aspirin has some notable adverse effects and drug interactions. For example, people planning surgery should be counseled to stop taking aspirin at least 7 days prior to surgery, although this may depend on the individual risk and the type of procedure. Note that some patients have a hypersensitivity to aspirin. Aspirin exacerbated respiratory disease, AERD, while rare on its own, is common with those who have asthma, rhinitis, and nasal polyps. AERD is also more common in women. Similar reactions may occur with NSAIDs. So first generation non-selective should be avoided. Aspirin and pediatrics. Do not give aspirin to anyone under 19 years of age during a fever-inducing illness. This is due to the correlation between taking aspirin with a viral illness and Ray's syndrome. Ray's syndrome occurs 3 to 5 days after the onset of a viral illness and starts with continuous vomiting. Symptoms progress to listlessness, somnolence, delirium, loss of consciousness, and ultimately death unless early treatment is initiated. For a list of medications that contain aspirin, see Ray's syndrome website. Aspirin for pregnancy and lactation. At dosages used for analgesia, 350 to 650 milligrams, aspirin is a pregnancy category D and can harm both mother and fetus. The use of high doses greater than 150 milligrams per day is associated with prolonged gestation and labor, maternal and neonatal bleeding, fetal growth restriction, and increased mortality during the perinatal period. Exceptions include the use of low doses, baby aspirin, dosages of 81 milligrams for antiphospholipid antibody syndrome and the prevention of preeclampsia, fetal growth restriction, preterm birth, and stillbirth, although effects are inconclusive at this time. Like other NSAIDs, aspirin may cause premature closure of the ductus arteriosus if taken at the end of pregnancy. A patent ductus arteriosus during fetal life enables the fetal blood to largely bypass the fluid-filled lungs and flow from the pulmonary artery to the descending aorta to supply the kidney and intestines before returning to the placenta. Closure occurs after birth and is important for a normal neonatal transition. Premature closure is problematic. See the following link for an explanation of the physiology of ductus arteriosus and prostaglandin inhibitors, NSAIDs including aspirin. Ideally, aspirin should be avoided with breastfeeding, but some guidelines allow use with caution. However, all efforts should be made to use a safer alternative. First and second generation NSAIDs. The members of the ibuprofen family inhibit both COX-1 and 2 pathways and are reversible inhibitors of platelet aggregation. They are generally more effective anti-inflammatory agents than aspirin and may cause less gastric upset. They are also more expensive. The primary difference between the drugs in this class is the different half-lives and potencies. Individuals have varying responses to different NSAIDs. It may take some trial and error to find the most effective NSAID for a patient. If one kind does not work, try one of a slightly different structural class. Also, lower doses are generally used for pain relief, while higher doses are used for anti-inflammatory effects, which may take as long as 2 to 4 weeks to manifest. COX-2 inhibitors have higher cardiovascular risks and lower GI risks. COX-2 inhibitors, in order to address the GI irritation that is common to most NSAIDs, a new class of NSAIDs was developed, the COX-2 inhibitors. To understand how they work, it is helpful to review the physiology of prostaglandin production. Prostaglandins are formed from a precursor called arachidonic acid. The enzyme cyclooxygenase converts arachidonic acid to one of the prostaglandins and or leukotrienes, which are potent bronchoconstrictors. Cyclooxygenase comes in 2 forms. COX-1 is around all the time and is a COX responsible for stimulating prostaglandin production in the stomach. COX-2 is produced by gene transcription in the presence of tissue injury. It then produces the vasodilating prostaglandin that causes swelling, erythema, and pain. The COX-2 inhibitor, Celebrex, selectively inhibits COX-2 and thereby has a markedly better track record with regard to GI symptoms and bleeding. Unfortunately, although it did seem COX-2 inhibitors decrease GI upset over other NSAIDs, they had other problems with safety. Vioxx and Bextra were removed from the market for causing cardiac abnormalities. There are also concerns about problems with the remaining COX-2 inhibitor, Celebrex, as well as with the non-selective NSAID naproxen, which is Aleve. If patients are to use Celebrex and have already failed trials with first-generation NSAIDs and other appropriate alternatives, They must be fully informed of its risks and use the smallest possible dose for the shortest amount of time. Contraindications for use of NSAIDs. Patients with kidney disease, bleeding tendency, and those using anticoagulants should not use NSAIDs. Those with a history of gastric bleeding should use only with extreme caution, only if all other appropriate pain relief measures have failed. People who are allergic to aspirin should not take other NSAIDs. NSAIDs may affect hypertensive control as they cause an increase in edema. A particular issue is their association with cardiovascular events due to their prothrombotic properties. Extreme caution should be used with those with cardiovascular risk factors and disease, and if used, should receive the lowest dose for the shortest amount of time possible. They are contraindicated for those with a history of MI or current unstable angina. They also have the potential for decreasing digitalis clearance, which could lead to toxicity. They should be used in extreme caution in diabetics and others who use ACE inhibitors because of potential damage to the kidneys. The stepwise approach published by the American Heart Association is a helpful guide to navigate this complex prescribing situation. NSAIDs in pregnancy and lactation. Technically, naproxen, which is also naproxen or Aleve, and ibuprofen are considered pregnancy category B in early pregnancy, while most other NSAIDs are pregnancy category C. Even so, NSAIDs are generally contraindicated during pregnancy, especially during the third trimester when they can cause premature closure of the ductus arteriosus, prolonged labor, and increased bleeding. Theoretically, aspirin at the dosages used for analgesia may have the same effect. Furthermore, a recent study showed that the NSAID used in the first trimester may cause major congenital anomalies, specifically cardiac septal defects. Therefore, during pregnancy, it is best to avoid NSAIDs altogether in every trimester. NSAIDs are the safest, highest known analgesic, second to acetaminophen in breastfeeding, and generally considered safe. However, watch for jaundice and provide the parents with preventive education and advice as well. NSAIDs may compete with bilirubin binding sites, which increase the risk for hyperbilirubinemia in the newborn. Non-NSAIDs analgesics. Acetaminophen, which is also called Tylenol or Tempra, is the final analgesic reviewed in this unit. Acetaminophen does not inhibit COX well in the presence of inflammation and therefore does not have an anti-inflammatory effect. However, acetaminophen is a good antipyretic and analgesic. In addition, this drug is not associated with the adverse effects seen with NSAIDs and may be used in infants, children, and in patients with chronic kidney disease. Acetaminophen, unlike NSAIDs, can cause toxicity if overdosed and may cause liver toxicity if used in combination with alcohol. Acetaminophen is contraindicated if the patient drinks equal to or greater than 3 drinks a day or takes other liver toxic drugs. A 2009 advisory committee advised a reduction in individual dosing and maximum daily dosing, which reflects one of the main guidelines in pharmacology: start low and go slow. Acetaminophen is the drug most commonly used for chronic pain in persons with past history of bleeding or GI problems or aspirin hypersensitivity. Note that it is an ingredient in many OTC medications and preparations. For this reason, when working with patients, particularly parents, advise them to dose products separately rather than purchasing combination products. Monotherapy helps in 2 aspects: monitoring the drug, and if an allergic reaction occurs, it is easier to identify the offending agent. While over the counter, acetaminophen can be a deadly drug when taken at higher than recommended dosage. New recommendations limit acetaminophen to 3 grams daily as it destroys the liver. Acetaminophen has been so popular in the United Kingdom as a method for suicide that the government has limited the number of tablets that can be purchased at one time. Since instituting these limits, there has been a drop in suicides by APAP overdose. Also, mission teams in developing countries have been cautioned not to give samples of acetaminophen for infant fever, as there have been infant deaths due to unintentional overdoses. Compared to NSAIDs, APAP has the advantage of causing minimal GI irritation, not interfering with bleeding times, and no effect on uric acid levels or respiratory rates. APAP is extensively metabolized by the liver. Avoid in patients with hepatitis, dehydration, liver disease, cirrhosis, or those who are heavy drinkers. The antidote is acetylcysteine. Acetaminophen in pregnancy and lactation. Acetaminophen is considered safe for short-term use in pregnancy and is compatible with breastfeeding. Muscle relaxants. Antispasmodic and muscle relaxants are used to treat muscle spasms and associated pain. They're commonly used for multiple sclerosis pain and associated with back sprain and spasm. There are two categories, those that act in the CNS and the direct-acting drugs or antispasmodics. Centrally acting muscle relaxants may cause CNS sedation and increase the risk of falls and injury, particularly in the elderly. Patients must be educated and cautioned about the risks and should not drive or operate dangerous machinery. Many are found on the Beers list due to the associated risk of CNS depression. Remember to consider additive effects of concomitant medications, anticholinergics, and other CNS depressants, and alcohol. Direct-acting antispasmodics are unique uses. Unit C, musculoskeletal conditions, headaches, and fibromyalgia. Headaches are a common complaint in primary care. Primary headache disorders include number 1, migraine, which is unilateral, throbbing, pulsatile, lasts 4 to 7 hours, includes nausea and vomiting, light sensitivity, may have auras, more common in women, and genetically linked. There are migraine variants that include focal neurologic findings. Number 2, tension. It is the most common headache and it is treated effectively with NSAIDs. Number 3, cluster, also known as the ice pick headache because it is unilateral. Severe pain behind one eye. Nasal congestion with rhinorrhea occur in clusters over weeks to months, often at night, more common in men and blacks. Mixed, a combination of tension and migraine headache. Rebound occur due to overuse of medications to treat headache pain. Medication actually causes worsening of the pain. Treatment entails discontinuing all pain medications. Migraine headaches occur in 20% of women, 5% of men, and 4% of children in the U.S. Cluster headaches are rare, but most common in men and blacks. Tension-type headaches are the most common type of headache and are usually amenable to NSAID therapy. Migraine and cluster headaches often require either abortive therapy, preventive therapy, or both. Ergo, selective serotonin agonists, caffeine, NSAIDs, antiemetics, beta blockers, tricyclic antidepressants, narcotics, or a combination of these drugs may be used to achieve relief from migraine headaches. The use of botulinum toxin A injections, although FDA approved for the preventive treatment of chronic migraines, has only demonstrated modest benefit. Lifestyle changes and non-pharmaceutical preventive measures are influential in some patients and include stress reduction, regular eating, sleeping patterns, reduction or cessation of alcohol intake, and tyramine-containing foods. Understanding the difference between prophylactic treatment and acute or abortive treatment. Acute therapy ranges from OTC medication to IM medication given in the clinic setting. Remember that due to pain response, severe pain can result in nausea and vomiting, rendering PO medication ineffective. Be sure to review and consider antiemetics in the treatment of acute headaches. Even in the absence of nausea, antiemetics act synergistically with pain medications. Many of the antiemetics also produce CNS sedation as a side effect, which may be helpful. Migraine headaches are managed in a stepwise approach. In addition to pharmacologic treatment, adjunct non-pharmacologic treatments are essential, such as an ice pack in a dark, quiet room. Ergos and triptans are effective treatments. Both are vasoconstrictors and contraindicated in pregnancy except for severe cases. Many reproductive age women present for headache. The SAFE provider recognizes the need to evaluate for pregnancy before administering these drugs. Likewise, considering the mode of action, i.e. vasoconstriction, the provider needs to evaluate and consider coronary artery disease and hypertension. And then there's a chart for stepwise treatment of migraine. Typical abortive treatments include triptans, which are selective serotonin receptor agonists. There's ursoalkaloids, such as ergotamine and dihydroergotamine, analgesics, NSAIDs, antiemetics, and combination products. Indications for prophylactic medications: if it lasts for greater than 2 months, if you have them for greater than 2 months, if attacks last greater than 24 hours, if they cause major disruption in ADLs and disability of 3 or greater days, if abortive therapy fails or is overused, symptomatic medications are contraindicated or ineffective. Use of abortive meds greater than 2 times a week. Migraine variants produce profound neurologic effects. Migraine preventive therapies, level A evidence, anti-epileptic drugs. Divalproex sodium, sodium valproate, and topiramate. Beta blockers, metoprolol, propranolol, triptan, frovatriptan. Level B evidence, antidepressants, amitriptyline, which is TCA, venlafaxine, SNRI, beta blockers, atenolol, nadolol, triptans, naratriptan, zolmitriptan. Fibromyalgia. Fibromyalgia is a syndrome identified by a symptom cluster rather than through any laboratory or radiologic findings. Treatments include both non-pharmacologic and pharmacologic modalities, a combined approach essential to treatment. Patients with fibromyalgia are highly sensitive to medications with a higher rate of adverse effects, so starting low and going slow is recommended, as is the case with the introduction of most medications in non-emergent settings. To avoid drug-to-drug to herbal interactions, patients should consult with their provider first before taking any over-the-counter or herbal products. There are 3 FDA-approved drugs for the treatment of fibromyalgia. There's milnacipran, duloxetine, and pregabalin. The levels of evidence for pharmacologic treatment are as follows: tricyclic antidepressants. Amitriptyline is grade A. Serotonin and norepinephrine reuptake inhibitors, SNRIs, such as duloxetine, which is Cymbalta, are also indicated for concomitant depression, is grade A. Milnacipran, which is Savella, has been shown to decrease fibromyalgia pain, fatigue, and improve function. It's a grade A. Selective serotonin reuptake inhibitors, SSRI. Citalopram has not been shown to be effective. It's a grade B. Fluoxetine has been found to decrease pain in patients with fibromyalgia. It's a grade B. Paroxetine has been found to improve scores on the fibromyalgia impact scores, such as grade B. Anticonvulsants, gabapentin decreases pain and improves fibromyalgia impact scores. It's a grade B. Pregabalin demonstrates benefits in fibromyalgia by improving pain, reducing fatigue, and improving sleep, as well as overall well-being, grade A. Other medications, cyclobenzaprine, which is a muscle relaxant, has a chemical structure similar to TCAs, which might explain its benefit in improving sleep, stiffness, and fatigue, grade B. Tramadol, there are conflicting studies on the benefit of tramadol in monotherapy for fibromyalgia. It's a grade C. This analgesic medication works as a serotonin and norepinephrine reuptake inhibitor, so it should be used in caution in patients taking SSRIs or SNRIs. Tramadol lowers the seizure threshold, so avoid in patients with this seizure disorder. Opioids, benzodiazepines, NSAIDs, magnesium, guaifenesin, DHEA, melatonin, and calcitonin have not demonstrated effectiveness. They are a grade C. And that's it.